Good evening, and thank you for attending AACP's webinar with Dr. Katwa presenting Pediatric Sleep Bruxism Diagnosis and Management. I'm Shaylin, the Association Manager for the AACP, and I will be the host of the webinar tonight. This webinar is approximately 45 minutes, followed by a 15-minute Q&A session. Please enter any questions you have in the Q&A box located at the bottom of your Zoom screen, and we will address them at the end of the presentation. Registrants can expect to receive a recording of this presentation via email within 10 to 14 business days, and AACP members attending live will receive their CE Certificate of Attendance within 30 business days. The AACP and Dr. Katwa have no conflicts of interest. Also, there's still time to register for AACP's Airway Anatomy Forum, taking place October 24th through 25th in Santa Clara, California. This unique event brings together leading experts from both dentistry and medicine to explore the critical connections between midface anatomy, functional breathing, and brain health. It's an incredible opportunity to deepen your understanding, connect with colleagues, and stay at the forefront of airway-focused care. I would like to turn it over to our moderator tonight, Dr. David.
Thank you, Shailene. Tonight, we're here to listen to a magnificent speaker, lecturer, worldwide lecturer, I have to say, Dr. Umakanth Katwa. He's a well-accomplished clinician. He's a pediatric pulmonologist and sleep specialist, and he's the director of the Sleep Center at Boston Children's Hospital. And he's also the assistant professor of pediatrics at Harvard Medical School in Boston. He did his fellowship training in pediatric pulmonary and sleep medicine at Harvard University. And he's also the director of the Infant Apnea Clinic and co-directs multidisciplinary sleep apnea and sleep surgery programs. He has extensive teaching experience and co-directs pediatric sleep medicine courses at Harvard and also at Tufts University. He is a member of the American Academy of Sleep Medicine, and he's also on the Sleep and Respiratory Technologist Education Task Force. He has many accomplishments, as you can see. His research interests include phenotyping pediatric OSA, infant sleep apnea, drug-induced sleep endoscopy, and technology integration in sleep evaluation. He lectures widely across the world and is involved in teaching sleep physicians, dentists, and medical students, and has been extensively published. And he's in several peer-reviewed national and international journals. He's all over the world, and we are privileged to listen to you, Dr. Katwa.
Thank you for inviting me for this presentation. I've been working with dentists for a long time, and I'm very passionate about the interaction with the dentistry and the medicine needs. And my area of expertise in sleep medicine, I think there is a lot of collaboration which needs to happen in co-managing these patients, because I think we are working in silos, and many times each one of the other specialties doesn't know what the other person can offer. So this is an attempt in that regard to understand how a pediatric sleep bruxism can be co-managed both by a medical specialist as well as a dental specialist. Because many times these patients end up with dentists, and sometimes they are diagnosed on the sleep study. So here we are. I don't have any conflict of interest to disclose. So this is an article published in 2018 describing the sleep bruxism, particularly generalized explanation about how this can be a bridge between dental and sleep medicine. Particularly, they focus on more on adolescents and teenagers, and the role of sleep physicians in evaluation of sleep bruxism using polysomnography, which is also called a sleep study, and how they can manage and in some of the difficult to treat patients. So as sleep apnea is one of the diagnoses which can be co-managed both by dentists as well as physicians, sleep MDs, I think this is another diagnosis which I think we can co-manage and work together. So this is the old terminology initially, it was coined by one of the French dentists, Bruxism. So in 1907, this is the first time they used this terminology, and subsequently this was changed to Bruxism, and that's what has been adopted into the literature. That's basically, it means you're gnashing or grinding the teeth, occurring without a functional purpose. So basically, when you're chewing, when you're talking, when you're eating, when you're swallowing, there can be some jaw movements which are functional, or like, they are with a purpose. But if there is a non-purposeful or just a functional movement of the jaw where you clench, where you grind, where you clench, that is of no functional significance, and these are called parafunctional, and that's what bruxism means. So bruxism doesn't necessarily mean that the activity what's happening with any function like eating, it is happening while you're not eating. So it's involuntary. So there can be voluntary grinding of the teeth because of anxiety, but this bruxism is mostly involuntary, particularly during sleep, when you sleep. It's a non-functional, repetitive jaw muscle activity characterized by clenching or grinding of the teeth, or by bracing or thrusting of the mandible. So it can be in various forms. You can just clench your teeth, you can just grind your teeth, you can grind backward and forward, you can grind on the sidewards, you can circular motions, and you can do combination of these things. So it can have, particularly during sleep, a phasic activity, which is very rhythmically contracting, or a tonic activity, where you go into a sustained contraction of the masseter muscle where the jaws is contracted. Or it can be a combination of both, again, of the jaw muscles. It has two distinct circadian manifestations. Circadian means your internal body clock. So there is what's happening during sleep. It is involuntary, particularly when you're sleeping in the lighter stages of sleep. And it also happens during wakefulness. The wakefulness bruxism can be a habit, or it could be a tic-like activity, more seen in children with ADHD, autism, Down syndrome, and can also be seen in some of the patients who are otherwise don't have any other medical conditions. So just it can be because of anxiety and things like that. And subsequently, sleep bruxism is what happens in any patients, even in healthy people. The International Classification of Sleep Disorders to list sleep bruxism as one of the sleep-related movement disorders. So there are various sleep-related movement disorders like restless legs, your parasomnias, or sleepwalking, or sleep talking. So this one is the movement of the jaw. It's also called sleep-related movement disorder. Initially, it was labeled as a parasomnia, but I think they subsequently changed. So in that definition, it is defined as an oral activity characterized by grinding or clenching of the teeth during sleep, usually associated with electrocortical arousals. Meaning, when you're clenching your teeth, your brain wakes up. So you're clenching your teeth so hard that it triggers an arousal in the brain. Sometimes you may wake up. Sometimes your brain goes into lighter stages of sleep and it causes sleep fragmentation. Sometimes the bruxism can be so annoying that the bed partner may also be not able to fall asleep, and it can be pretty irritating for the bed partner if they are a light sleeper. So these are some of the diagnostic criteria used, because once you have a condition, this is how it is defined. So it is defined as the presence of a regular or frequent tooth grinding sounds occurring during sleep. So many times to diagnose bruxism, one of the bed partner or parents come and tell you that, oh, my child is grinding the teeth during sleep. Nobody comes and tells you that you're grinding your teeth myself, unless they bit their tongue or cheek or something like that. So most of the time, it's recorded by the parents or the bed partner. And then in addition to that, there has to be one or the more of the following. So just the history is not sufficient. Either there's an abnormal tooth wear consistent with the above, you see some tooth damage or like flattening of the teeth, or transient morning jaw muscle pain or fatigue or temporal headaches. Or sometimes you can have TMJ symptoms like jaw locking, and it can be like a stiff jaw kind of situation. So here's the difference what we're trying to see. Sleep-related bruxism, when you define as a disorder, they need to meet this criteria. But many people have bruxism, which is not a disorder, meaning they have like a very brief intermittent bruxism. They don't have any significant wear and tear of the teeth. or they may not have any daytime symptoms or jaw symptoms. So there could be a milder version of this, which is not a disorder, it's just a symptom. So it's quite common in general population. And in the sleep world, is the third most common sleep-related movement disorder. So activities during sleep, which are abnormal, and this is the third most. The first one is the restless leg, those kind of situations. Adults with bruxism can also have a childhood history of bruxism. So many times the history predates into their childhood. It can affect all the ages. Even in infants can have teeth grinding, and particularly starts with their primary dentition eruption. So this is the prevalence. And if you see from childhood all the way to the older adults, the prevalence is quite common. Again, it's a symptom at this time rather than a big disorder. Over a period of time, the children outgrow this. And then about 8 to 12% of the adults have this. And over 3 to 5% of the people over 50 have that. So it's less common as we get older, but it's pretty common early childhood. But the impact of the thing can, depending on how severe is the bruxism. So this is what it describes. And it's equal both in male and female. So this was a large Canadian study. They actually did a survey and also used the sleep study in about more than 6,000 patients who were studied in the sleep lab. And they found that about 8.6% of the general population were diagnosed with bruxism based on the sleep study. That means you have a definitive diagnosis of bruxism, which can be documented. And they also felt that it decreases with age, as I talked about. 1/3 of them reported pain because of the bruxism. And if there is a family history of bruxism, there is a 2.5 chances that the child also has bruxism and vice versa. So again, different studies have shown between 37 to 40% of the family members can have first-degree relatives who have sleep bruxism. Then, so let's talk about the sleep and the bruxism. So when we talk about that, so let's talk about what is the effect of sleep on bruxism. So why do people brux? So there is a lot of research going on and a back and forth about a chicken and egg situation. Is that the bruxism came first and affecting the sleep, or the sleep issue came first and affecting the bruxism or resulting in bruxism? So either way, you can argue on both the side of the aisle, and the jury is out there still, like no clear consensus, but these are affected on both ends. So bruxism is a sleep-related phenomena, and it has been postulated that it is because of the unstable sleep or the sleep state instability mechanism, particularly involving the arousal processes in the non-REM sleep. So sleep bruxism can also happen in the REM sleep, but it is very, very rare. REM sleep is your dream sleep. So which is about 20% in adults, is about 30 to 40% in pediatrics. So it happens during the unstable, lighter stages of sleep, particularly in the non-REM sleep. It typically does not happen when you're in the very deep sleep. It happens when your sleep is unstable. This RMMA means repetitive masticatory muscle activity. So about 80 to 90% time you would clench your teeth because of the repeated clenching leads to an arousal, meaning you wake up from your sleep. And sleep bruxism may also be secondary to exaggerated transient motor or autonomic activity. So if there is a stress in the body, the stress could be because of your anxiety, the stress could be because you have sleep apnea, you're not able to breathe better, or stress could be because of your oral hygiene or oral inequilibrium. So whatever it can cause stress to the body can lead to unstable sleep, and that can trigger into various muscle activities. One of them is sleep bruxism. So now, what is the effect of different sleep stages on bruxism? So the frequency of the rapid muscle activity is modulated by the cyclic alternating pattern. So if the sleep is unstable, as I talked about, that leads to periodic burst of bruxism. It comes and goes. It's not all night. It comes in bursts for a period of time. Then it gets better over the night, and then it comes back when the sleep is a little bit unstable during the night. Most of these muscle activities in the jaw are seen in lighter stages of sleep, as we talked about. And sometimes they can also be seen in REM sleep. So typically when you brux, it causes microcell fragmentation. So because of that, when you wake up, you feel very tired, you feel non-refreshed, you may feel sleepy. So many patients may think that they have a sleep disorder, And they may think they have sleep apnea or insomnia because daytime fatigue tiredness is also a symptom of this disease. Particularly in young children, they can have attention issues and they can also be diagnosed with ADHD. So significant sleep bruxism, untreated, can cause sleep disturbances, sleep fragmentation, and because of that, the kid can have significant daytime symptoms like attention issues and ADHD. So I have to treat those patients. Particularly reported to be worse when you're on your back, when you're supine position. And a sleep bruxism can also trigger a night terror or a nightmare, like any other parasomnia. So if you suddenly grind your teeth and your brain suddenly wakes up, you can trigger a night terror. So when I'm evaluating children who are more than 6-7 years old, having night terror for the first time in their life, I ask this history of sleep bruxism or sleep apnea, or snoring, and things like that. Many times these both can coexist. So it's very, very important for us to ask this history in patients from the medical point of view. So now, what is the pathophysiology of sleep bruxism and like how does it cause? What are the main causes? So again, it's very debatable. People are still figuring it out. But out there are three main mechanisms. Number one is the central causes, which is from the brain. Number two is the peripheral causes, which is in the mouth or the dentition area. And number three is the psychological causes of sleep bruxism. So again, there are various theories I talked about. There are theories which are dark line, which are a little bit better proven by studies. These on the dotted line are possible mechanism which should be explored or could be contributing. So one is your autonomic activity, that is the stress level in the body. That could be because you're breathing under stress, your airways are narrow, you're trying to work hard to breathe, and because of that, you go into lighter stages of sleep or a unstable sleep pattern, and that triggers autonomic activity, increase autonomic stress, and that leads to muscle activity like twitching, restless legs, and bruxism. So this is one thing, and hence it is very, very important that if you're treating a patient with bruxism, you have to evaluate the airways. A compromised airway can lead to stress in the body, and that may lead to bruxism. So you cannot treat just bruxism with a mouth guard without treating the cause in those patients. Again, there are various neurotransmitters because of the stress response, either non-adrenaline dopamine, serotonin, histamine, all these receptors, like neurotransmitters are involved in sleep and wake regulation and muscle activity during sleep. And hence, these are somehow contributing. We don't know exactly which one, but there are multiple neurotransmitters affected. Again, there are some patients who have maladaptive patterns, meaning if they're anxious, they just either try to bite their nails or try to be very fidgety, or they may also cope up abnormally by bruxism, by clenching the teeth and making them feel secure. So it's a maladaptive behavior, and that can trigger into daytime bruxism and also persist during nighttime. There is a genetic candidate they're looking for because there is a family correlation. I talked about 30 to 40% of the patients. So we don't know exactly what it could be. It is co-associated with sleep apnea or something else. So, but this is being worked up. And also the circadian rhythm, meaning it happens particularly during sleep. So it follows particular pattern. But in certain patients, it can also happen during daytime. So it can have a variation and happens mostly during sleep. The one thing for us, which is very, very important, both for the dental world as well as the medical field, is there is a high prevalence of bruxism in patients with a smaller jaw and tonsillar hypertrophy. So these are the one thing we really can do something about it. And we have to make sure that we evaluate the patients with sleep bruxism for the airway issues. So this is a diagram which particularly showing, let me walk you through. This is the EKG, right? This is the QRS complex on the top. The closer the QRS complex, the higher the heart rate, the further the QRS complex between each other, the slower the heart rate. This is your EOG, the rapid eye movements. This is your blood pressure. They were monitoring the blood pressure, systolic and diastolic. You can see it is nice. This is your effort, respiratory effort, and this is your EEG, which can tell you you're awake or asleep. And this is the masseter muscle activity during sleep. So if you think the red line here, this is where the bruxism starts. You can see that the patient has, with the bruxism onset, the blood pressure goes up. There is an arousal. There is a rapid heart rate slightly. You see the distance between these two and these two. So this is a slightly increase in the heart rate, elevation in the blood pressure, and also there is an arousal there. That means your brain woke up briefly and you had this multiple 1, 2, 3, 4, 5 clenching activity. So if this happens repeatedly your blood pressure can go up. Repeatedly your heart rate goes up during sleep. And how much does the blood pressure go in? So this is another diagram which shows that this is your diastolic blood pressure and a systolic blood pressure. And if the patient just has an arousal not associated with bruxism, there is a slight increase in the blood pressure with every arousal. That happens, but it comes back to normal. But if it's associated with the bruxism, the intensity of the increase in the blood pressure is much higher. You can see that, both systolic and diastolic. So it goes from 90 to almost 120 momentarily. So it's about 30-point increase in the patients. And if the patient is affected with the body movements, if there is also the leg movements, it can even go further up. So basically an arousal which can be a slight transient increase, if associated with the jaw movement of bruxism, you can see a dramatic increase in the blood pressure. So if there is a significant bruxism going on, those patients can have a significant increase in the blood pressure multiple times during the night, leading to daytime hypertension also. So if there is an adult patient has severe bruxism, invariably they will have some degree of hypertension, or they are a patient of hypertension and they are using medication. So there can be a correlation. By controlling bruxism, you can actually have an impact on their blood pressure monitoring. So from the central point of view, it can be said that there is an imbalance, or can be postulated that an imbalance in the neuronal plasticity of the basal ganglia because of the various neurotransmitters involved during sleep, like dopamine and norepinephrine. Nicotine stimulates central dopaminergic action, which plays a role in twitching, and hence smokers have a higher incidence of bruxism. SSRIs, like antidepressants, like these are serotonin reuptake inhibitors, indirect action through the dopaminergic pathway can also trigger bruxism. Hence, dopamine plays a known central role in the causes of sleep bruxism in patients. And also, it also plays a significant role in the restless legs of the patients. So hence, I call a sleep bruxism as the restless jaw syndrome, like the restless leg syndrome. So, and the peripheral causes, if the equilibrium in the mouth, in the oral cavity is lost because the malocclusion, tooth malalignment, retrognathia, mouth breathing, or whatever it is, and that leads to irritation, and that can trigger activity causing bruxism. And you have to, as a dentist, look up for the peripheral causes. And this is where you can really do something about it. If there is a malocclusion, you can align the teeth or do an expansion and align as much as possible. Myofunction therapy, if there is a mouth breathing, if the tether tissue, you can help release the tether tissue and help create a better equilibrium in the mouth. And other psychological factors are stress, anxiety, and coping mechanism. And that's the personality trait. So these patients, I always send them to be seen by a psychologist or a psychiatrist, and management of that can have an impact on this management of bruxism. So these are some of the comorbid conditions seen in patients with bruxism. Like these are the sleep disorders which I see in my clinic. They have sleep apnea, restless legs or leg movements. These are REM behavior disorder. These are sleep disorders. If there is seizures during sleep, history of night terrors or reflux, or the patient is waking up frequently with night terrors or confusional arousals, or they have a lot of myoclons during jerks in sleep. So these conditions are at a high risk of developing bruxism. And all the neurologically developmental disorders, tardive dyskinesia, cerebral palsy, Parkinsonism, all those patients can have sleep bruxism, particularly in the early phase. And then psychiatric conditions like stress, anxiety, dementia can also have sleep bruxism. But the one important thing which I want to talk about is the medications. When you see a patient with bruxism, I think it's extremely critical to ask the medication history. So there are medications, if they are on the significant doses of serotonin reuptake inhibitors, sometimes they may be contributing to the bruxism. Hence, you can, if it is too much of a damage to the tooth, you can have a discussion with the psychiatrist or psychologist to see that they may have to consider changing those medications or switching to something which is less irritating. Haloperidol, lithium, a lot of stimulants. These days, children with ADHD are on stimulants. So that is extremely important for them to get treated for that one. And even a secondhand smoke exposure in children. Smokers, particularly some of the older teenagers, and secondhand smoke exposure, drug abuse like cocaine, alcohol, caffeine, particularly excessive caffeine, like these Red Bulls kind of thing, can also trigger bruxism, particularly in your patients if they have significant tooth damage. A good medication history is very, very helpful to understand if they are playing a role or making the things worse. Again, these are some of the risk factors in one of the study published by Dr. Gamenau, who is considered the father of pediatric sleep medicine. He's no more. He was in Stanford. So I talked about initially sleep apneas, snorers, or if the patient has an ENT problem like recurrent otitis media, if the patient has ear discharges or tube placements, those patients are at a high risk of developing bruxism. Again, we talked about caffeine, smokers, anxiety. Thumb sucking and pacifier use is somehow shown to be associated with increased risk in some of the patients. A restricted tongue mobility like tongue ties, and particularly some of the syndromes, it's very, very high. You always need to watch them out. This is another paper, like a study published by Dr. Simmons from the sleep medicine. They were postulating that, you can see, this is the sleep study. These are your EGs. This was your snore channel, and this is the breathing effort. And then there is an arousal here, like a lot of activities. You can see this patient was snoring, and suddenly takes a big breath. And once he wakes up, he goes into repeated 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16 times he's clenching his teeth. So this is one episode of sleep bruxism with about 16 to 17 episodes of teeth clenching. And that can lead to, see the heart rate was 45 in this patient sleeping. It jumps to 85. Unfortunately, we could not measure the blood pressure in this patient. So you would have measured the blood pressure, it would have gone up also. So again, it's very, very important to understand that if there is a snoring, even not necessarily frank sleep apnea, even a mild degree of upper airway resistance with the increased stress of breathing can trigger these episodes. And this is how a bruxism episode slips on the sleep study. And this is another study where they actually try to identify functional craniofacial features in about 96 kids, published one of my friend, Dr. Yoon and Dr. Levine from Canada. And they actually evaluated 96 healthy kids, 6 to 12, from routine dental examination at the UCLA Pediatric Dental Clinic. So they found that basically based on the history, this was just the probable sleep bruxism significantly associated if you have impaired nasal breathing, your blockage in the nose, or you have a habitual mouth breather, or you have restricted tongue mobility, or your tonsillar hypertrophy. So these makes, you can see the orange ones. If the tonsil size gets bigger, the incidence of bruxism, the orange line gets up. Again, the orange one, if you have limited tongue range of motion, your bruxism increases. And if you combine these three, you can see this, the orange, the bruxism increases. If you have all three, you have a high risk of developing sleep bruxism. Again, there are a lot of studies published that sleep bruxism and the myofunctional and TMJ disorders and self-reported cases in TMJ-associated patients, particularly older teenagers, can have over 55% of the time can be associated with sleep bruxism. And bruxism is also associated with reflux. If somebody has a significant reflux, either a child or an adult, the odds ratio is about 6 to 7 times developing sleep bruxism compared to a normal population. Hence, you always have to ask about reflux in these patients. So when a patient comes to your clinic, so what are the questions you're going to ask? Like, how do you start the discussion? You can ask that rather than you grind your teeth, and you can ask the parents, has anybody or you heard your child grinding your teeth at night? They may not be aware because of their co-sleep. Many times when they're traveling for vacation, staying in the same hotel room, they may hear that. So it is important, or they can ask them to keep an eye if you see wear and tear on the teeth. Is your jaw ever fatigued or sore on waking up in the morning? So it's very difficult to ask these questions for a younger child, but you can ask them for teenagers and adults. Are your teeth or gums ever sore on waking up? Again, that depends on the age of the child to answer that, but you can always try to examine and feel any tenderness. Do you ever experience temporal headache? So if somebody is complaining, particularly an older child in the morning headaches, that could be one of the signs of sleep bruxism. Hence, you can ask about, or you can feel the masseter, you can examine the patients, but you can ask the questions in several different ways to identify or keep an eye for bruxism if you see any changes in the teeth. So the long-term consequences, particularly from a dental perspective, it's significant. It can cause significant tooth damage, dental erosions, tooth sensitivity, even fracture. It can also, in addition to the tooth, can cause people have bitten their tongue or the cheek. It can also cause facial pain because your muscles are contracting all night, which is out of your control. Headaches in the morning, masseter muscle hypertrophy, temporalis muscle hypertrophy, TMJ pain. It can cause. In many patients, from a sleep point of view, if you're not sleeping well or waking up, you can have insomnia. Because of that, you can feel tired in the morning when you wake up. So it can also cause sleepiness and fatigue. So particularly children with significant bruxism causing sleep fragmentation, it can have a significant behavioral or attention issues. So you can precipitate ADHD in some of the bruxism patients if it is significant. And many times we are either giving medication for ADHD rather than addressing the root cause like bruxism or sleep apnea. So when you examine, so particularly as a physician, I do a thorough airway evaluation, looking for the nasal obstructions or oropharyngeal obstructions or other things. So I look for the Mallampati classification, which is basically trying to look at the mouth with the tongue protruded and try to see if you can see the back of the throat and also the tonsils. If you're not able to see the back of the throat and only the hard palate is grade 4, where it is a very crowded airways, if you can see the uvula nicely and back of the throat clearly through the mouth, then it is 1. So the 3 and 4 are in between them. Typically, if there is a malocclusion, macrognathia, you see the patient profile, nasal allergies, and adenoid faces. So these are the things we look for. From the dental examination, again, I'm not a dentist, but I try to do some like very basic examinations, and I send it to my dentist. Look for the tongue wear. Sometimes, there's a tongue indentation because of that or trauma, and also tooth wear and tear, tooth tenderness, and sometimes you can obviously see the fracture. But I try to feel their older child's masseter hypertrophy or temporalis hypertrophy or jaw tenderness. I think sometimes you palpate the TMJ and see if you can hear any other pain or irritation in that area. And also in severe bruxism, obviously neurological patients, we do a neurological examination. Many patients already have a neurological diagnosis like cerebral palsy, and that could be because of that underlying condition. This is how a tooth looks like. And this is, you guys know better than me. So you can see enamel, the dentin, and the pulp here with the gums, and nice, curvy shape of the tooth. And with the grinding, it can just get flattened. And depending on how much you grind, you can keep going into the dentin, and subsequently you can hit the pulp. So it can just erode the teeth depending on the force of the teeth. And again, early phase, you can lose this because of that. There can be some attrition, and healthy teeth, as you know, should have like a nice looking round surface. And these are some of the images of the patient with the fracture of the teeth because of the bruxism. You can see this here, and also the patient who has been flattening of the anterior teeth, particularly because of the bruxism. And I can grade them on the attrition scale from 0 to 4, where there is 0 means no loss of enamel, 1 is a minimal surface change, 2 is enamel loss with the limited dentin exposure. Number 3 is enamel loss with the extensive dentin exposure of more than 1/3, and the grade 4 is enamel loss with the exposure of the pulp. So basically, this you lost almost all of this, and causes secondary dentine can also be lost. So these are some of the images. Again, I just found them, which can be looked into. Most of the children's, younger the children's, you can see more of the anterior tooth wear. Older the kids, you can see some of the molar and other teeth wear and tear. And also some of these patients can also have significant loss of teeth in these areas. As far as the ear examination I talked about, airway, turbinate hypertrophy, you can also see enlarged turbinates in the CBCT if you're done for some other reason. Deviated septum, large big tonsils with huge uvula, adenoidal hypertrophy, And if you've done an SCVCT for an other orthodontic reason or airway reason, you can clearly see there is a narrowness of the airway and the low tongue posture in this patient. So again, depending on what you see, you always have to rule out any airway compromise in these patients. Some of the examinations and could be just the profile of a child. You can see myofunctional issues, the low muscle tone of the face. Particularly, they can have a retrognathic mandible, and they can have crowded teeth and adenoid faces. Similarly, you can also look for tongue range of motion. There are various techniques to see how much you can move, whether you have tethered tongue, tongue tie, or it is like freely mobile tongue, and you can see how much in the mouth you can open. So there are various ways of assessing that and also looking at the malocclusions. So how do you evaluate sleep bruxism? Obviously, you have questionnaires to ask for them. You also do a clinical diagnosis based on the history that mom says my child is grinding their teeth. You look for the risk factors, ask for other history of sleep apnea, snoring, and daytime sleepiness. Do an examination, what I talked about, the airway examination, oral cavity examination, tongue examination, myofunctional examination. Also look at the dental examination, but always refer to the dentist in my area. And then also follow the diagnostic criteria. How do you diagnose them other than the history? So many patients, measurement of the pressure exerted on the occlusal split. Some people try the EMGs in the masseter muscle and see that. And the best way to actually diagnose sleep bruxism is a sleep study. You can also diagnose in the in-lab sleep study. In the adults, in the older patients, teenagers, you can use the home study with the leads on the masseter. So you can definitely use that. So this is the American Academy of Sleep Medicine diagnostic criteria based on the sleep study. So here we talked about, so the definition which I showed you has been replaced by this. So now they say that your bed partner is hearing the snoring sound, or somebody tells you they are grinding at least 3 to 5 nights a week. You're not just doing once in a while. And the symptoms should be at least for 3 to 6 months. And in addition to that, they should have all the symptoms of wear and tear, hypertrophy of the muscles, fatigue and tiredness. These symptoms cannot be explained by some other medical conditions, like anything with the neurological conditions, it's happening like a seizure. So you have to rule out, and then you call a sleep bruxism. And there are 3 possibilities and probabilities. If you just have a self-report or a history by the parent, you possibly have bruxism. If you have a clinical signs of wear and tear with a history, you have probable bruxism. And if you document that on a sleep study, you have a definitive bruxism. So this is how they clinically use. Many people treat in this area. Very few people come to this one. And incidentally, we find a lot of bruxism in a sleep study done for an airway issue. And also we can score, like we score sleep apnea, we can also score the bruxism, depending on how much the teeth are being clenched. And this is the criteria by the Sleep Academy. And depending on that, we can give an index, like we have an AHI, like an apnea hypopnea index. We can also give a bruxism index. There's a number of sleep bruxism events per hour. Typically, if it's less than 2, it's normal. If it's 2 to 4, it's mild. And above 4 to 10 is moderate, and anything more than 10 bruxism hours is pretty significant. And they can also calculate the impact on the sleep fragmentation, co-associated sleep apnea, co-associated periodic movements of sleep, and all those activities can be seen on a sleep study. And the report of the sleep study should be taken into context about all other conditions coexisting together. This is another sleep study. While we're doing this, you can see this muscle activity, clenching. You can see the artifacts in the EEG. This person also has the leg movements at the same time. You can see the right leg chin. The patient is also twitching the legs. So sometimes your clenching of the teeth with the artifacts in the EEG, you can count them, can also be associated with the leg twitching. Same thing here. This patient has bruxism, and he goes into 1, 2, 3, 4, 5, 6, 7 episodes of clenching. And similarly here, you can see this green line indicates a bruxism episodes. So these are different stages of sleep. This is awake. The red line is a REM sleep. This stage 3 is the deep sleep. Typically, the deep sleep happens in the early part of the night, and the REM sleep happens during the last part of the night. is typically much more common in the stage 2 sleep, but you can also see in the stage 3, but very, very rarely. So it's more common in the stage 2 sleep, rarely in the REM and in the stage 3. So this is how it appears. And this is one of my patients, which we were doing a sleep study for sleep apnea. He was sleeping, and you can see he was bruxing. And again, you cannot hear it. It was very quiet. And he was doing some swallowing motion after that. And then he does another bruxism. And after that, he takes a big breath, and he has a pause in his breathing. Then he takes multiple bruxing. He's grinding. I don't know if you can see that in the video. Again, there is no audio. He was like very quiet otherwise. And then he goes quiet, and there is an apnea. Then he takes a big breath, and that triggers an autonomic activity. Then he again leads to the bruxism and multiple. So this goes 1, 2, 3, 4, 5. So these are like 4 to 5 in each episode. So then you count them, then you divide by the hour. So these are your bruxing episodes happening repeatedly in these patients. So in the time course, when the patient has bruxism, so how does it work? So there is a whole cascade of activity happening in the body when you're about to brux. So your body stress level goes up. It can happen with increased cardiac output or sympathetic activity or sympathetic predominance. So normally, if you are in the parasympathetic predominance, your body is much calmer. Your heart rate is very stable and slower, and the blood pressure is the lowest. If there is a sympathetic surge because of the stress or difficulty breathing or snoring or irritation of the nerve somewhere or excessive dopaminergic activity, that leads to sympathetic activity, and that leads to increase in the brain activity. I'll show you another graph after this. That leads to 4 seconds before your brain activity starts more active, and then there is a tachycardia about a second before your heart rate starts going up. You take a couple of big breaths, and your like tongue tries to move, and at that time you start this bruxing activity. 1, 2, 3, 4 here. So the muscle is quiet here, your masseter muscle, and you can see the activity, and you have the grinding episode. And after each episode, you swallow, and that's the normal sequence of events. And you can show here. So this is the same thing you are monitoring. This is the sympathetic activity, the EEG with your brain waves to calculate the arousals, your EKG to calculate the heart rate, then the hyoid bones, the jaw opening muscles, airflow, blood pressure changes, masseter muscles, and then the swallowing mechanism. Okay, if you can see here, this is the onset. The red line is the onset of the bruxism. Your sympathetic activity, your body is already under stress. When the stress level peaks, at that time you brux, and then you give up that stress literally. And you can also see your heart rate, the difference. The wider the QRS complex distance, the smaller, the lower the heart rate. Shorter the distance, the faster. And in addition to that, when your blood pressure jumps up here, you can clearly see the significant blood pressure increase. And the blood pressure, because of the increased activity, it starts rising even before you start bruxing. And then with the bruxing, it jumps up again and then slowly comes down with this multiple bruxing activity. So there is tachycardia, there is arousals, increased stress response, blood pressure response, heart rate response, and terminating in the swallowing reflux. So this is an entire cascade, how your body is responding to a simple brux. This happens with every brux. And if the patient has bruxing all throughout the night, multiple times, you can see the effect of blood pressure on your body, and particularly somebody who has a difficulty to control blood pressure, or somebody who doesn't have a blood pressure or eventually will get blood pressure. So this is very, very important. And this can lead to sleep fragmentation and leads to daytime symptoms. So there is another condition called kathathrina. So this is basically moaning or groaning during sleep. And this is the type of parasomnia. And sometimes people confuse with the bruxism. Bruxism is the grinding of the teeth. And here, if you're moaning like an expiratory moan, so that's called sleep like a kathathrenia. So in those patients, there can be same mechanism acting like a sleep stage instability, but these then are two different conditions, and they can also be co-associated. So if you look at this one, it can occur in close temporal association, often linked to the cyclic alternating pattern. It basically means that you have an unstable sleep pattern which is a marker of sleep instability. That means your sleep is not going into a stable sleep. You are in a very wobbly or an unstable sleep. And because of that, there is an increased stress response in the body. And then you have this activity. So this patient had snoring sound in between. This is like, and you can see these green ones are obstructive hypopneas. But every time at this episode, he was like moaning. I'll try to see if I can play the audio for you. You can hear that. So this is the patient we saw who was having this abnormal motion here. And this time he was waking up, wake up, wake up, wake up. You can see his sleep is fragmented and very choppy. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16 awakenings in about 2 minutes. In a minute, he was having about 8 awakenings. So imagine how much if you sleep it for the entire hour or multiple hours. You can see microarousals, you can see it's marked here. So that was having these episodes. And this is the patient who was, you can hear this. You can see sound, that's the sound he was doing this. It's a sleep moaning sound where they try to close their glottis and try to breathe forcefully, producing that sound. So this patient was sleeping and having these episodes. See, he doesn't have a bad sleep apnea, but he was just having these multiple awakenings and episodes. He was like, restless. And if somebody sleeps next to him, they cannot sleep in his room and he will be very, very uncomfortable. You can hear that sound. He was moaning. So that can happen all night, multiple times, can also give us to significant daytime issues. And this can be associated with bruxism sometimes, but needs to be differentiated from that. This is another thing with moaning episodes causing a lot of sleep disturbances. You can see this EEG activity is very fast in those patients. So now, how do we manage these patients? Basically, the multiple risk factors, sleep hygiene, rule out sleep apnea, other things. For dental management, we can do occlusal appliances. Remember, by giving this, you're only trying to prevent the damage to the tooth, which is very, very important. But it does not cause change in the behavior in the first place, like the bruxing. So hence, if somebody has a significant bruxism or they're breaking through these appliances, you really have to make sure that you are seeing a doctor for the sleep bruxism so that they can use medications or something like that. Again, if patient has enlarged adenoids and tonsils and we are bruxing, following adenotonsillectomy, there is a significant increase in the bruxism. It decreased from 25% to 7% of the time. So it's very, very important that treating sleep apnea either by tonsillectomy or whatever mechanism can have an impact. So it's very, very important. Number 2, if somebody has sleep apnea and there are no tonsils, you start them on CPAP, the bruxism goes away. So if a teenager or an adult who has sleep apnea, by giving a splint, which may not help, you can have to give them CPAP. In some patients, you can also use palatal expansion. Like they have crowded airways, narrow airway, malocclusion. They may be a perfect candidate for alignment of the teeth and expansion. And after that, you can see a significant reduction in the sleep bruxism. So a palatal expansion in the patient will be an indication when there is a comorbid airway issues, malocclusions, overcrowding, narrow palate, loss of equilibrium in the mouth. You can definitely consider that. And also, there are some patients where we use the mandibular advancement devices, especially in adults, it works well. But in children, you may sometimes make the sleep apnea worse. So you have to be a little bit careful when you use the oral appliances. If somebody has reflux, I use the anti-reflux as a trial, and many patients it makes better. So basically, you have to evaluate by your orthodontist colleagues, dental colleagues, ENT colleagues, depending on where they go, they can get mandibular appliances or CPAP for treatment. In some patients with a lot of anxiety, cognitive behavioral therapy, physical therapy, low muscle, again, myofunction therapy can be done, but again, that in itself will not fix it. The release of the tethered tissue will help it. And if nothing is helping, then you have to go on medication. So you treat the comorbid conditions, you treat sleep apnea, you treat the oral hygiene and oral issues and airway issues. And if nothing helps, then you may have to go some medications. So obviously, stopping caffeine, alcohol if they're teenagers or older adults, good sleep hygiene, getting good quality of the sleep, sometimes hypnotherapy, biofeedback, particularly daytime, bruxism, it will help work. And then ultimately, there are some medications we use, either clonazepam, clonidine, gabapentin, or and in adults, some of the TMJ issues or other issues, botulinum toxin can be used because of the spasm of the muscles. They can use those things. In many patients, there is an iron deficiency. I try to treat iron deficiency with either oral iron or IV iron, and many times they get much better. So I directly don't jump to the medications. The medications are my last resort, and I use it for a short period of time until I fix some other comorbid conditions. Again, in summary, for management, these are our options before we go to the medications. And it is a co-management to protect the teeth and prevent the patient from bruxism again. Overall summary. So sleep bruxism can be either idiopathic or associated with secondary to sleep disorders, such as sleep disorder breathing, snoring, mouth breathing, or any neurological condition or psychological conditions. Not all patients with sleep bruxism have current complaint of tooth grinding. So many patients you may find incidentally, or you see there's a variant teeth in the clinical exam, then you ask them the questions. It can cause significant sleep disturbances by sleep fragmentation leading to daytime sleepiness. And sleep bruxism management with a maxillopalatal occlusal splint sometimes in young children can make things worse. So you may have to make a choice whether you're going to use oral appliances or CPAP, but CPAP really works, but many patients don't tolerate CPAP. So I think this is an important aspect in a co-management of a patient with better communication, understanding various challenges in the patient, understanding what you're treating, what the risk of recurrence, or is it possible to cure these patients? Particularly in the children and adolescents, I think the goal should be to cure the patients over a period of time by working very closely with the dentist and the myofunctional therapist or ENT, orthodontist, or a sleep medicine specialist. Thank you.
Dr. Katwa, that was an incredible lecture. It was so much information, and thank you so much. We have some questions for you. Let's see. Would you subscribe to the idea that bruxism at night could be functional in terms of clearing the oropharynx with tongues that fall back into the oropharynx, or with a Malampati 3 or 4?
It's not a functional motion, typically based on the research I've read about. So the biggest thing for me was undisputable evidence that the sympathetic activity increases before that. So when the tongue is falling back, there is an increased resistance to breathe. So when you're working hard to breathe, your body goes on the stress mode because you're working hard. That stress increases the sympathetic activity. And in some patients, the way the sympathetic output comes is in form of bruxism or sleep moaning or restless legs or twitching of the legs. So the sleep bruxism in patients with airway issues, not all sleep bruxism have airway issues, but in those things is a response to the stress of a breathing rather than trying to pull the airway forward.
Mm-hmm. This question followed by, it says here, Dr. Malik is asking, since bruxism is episodic, in your experience, how frequently do you catch bruxism during a PSG? Polysomnia.
Yeah. Great question. So if I do 100 PSGs, I may catch about 5 to 8 times in that. Again, it all this depending on the type of patient's ID. We see a lot of patients with Downs and autism. We see a lot of bruxism in those patients.
Mm-hmm. Let's see. This, I think the first question I already read, but the first question was also asking posture intention in the muscles of the tongue and jaw to depress the tongue in order to open the airway at night.
Any loss of equilibrium, either osteopathically or myofunctionally, a portion of the tongue or a tether tissue, anything which is the strain in the body will lead to bruxism. There may be other hidden causes which I don't know because I've not read about them, because of the tether tissue and the connection to the entire fascia system. When the body is under stress, any change of that position during sleep can initiate a stress response. So anything the stress increases, one of the output of the stress is bruxism. And it could be manifested with when you swallow, your tongue comes up to the palate and a little bit back and then forward. because when you swallow, your tongue goes back. So those moments, people can confuse that the tongue is trying to come forward because of the sleep apnea. Actually, that is a swallow mechanism following the bruxism rather than an airway correcting mechanism. So it's very tricky to understand and differentiate, again, depending on whatever research I've read. There could be some movement of the tongue for swallowing. It's not necessarily that the tongue is trying to unblock the airway. It may be, but it is not. There is no evidence to prove that.
Mm-hmm. I think that's all for the questions. Dr. Katwa, such a great lecture. It's so refreshing to have a sleep doctor, pulmonologist, such a knowledgeable person like you talk about bruxism in children, understanding the airway, and talking in the language of us dentists is such a privilege to have learned from you tonight.
Thank you.
Thank you so much.
Thanks all. Have a good night, and we'll see you back some other time. Okay.
Yes. Thank you.